thank you again for being here and sharing. I think it's so important to get to know where people are at, especially, part of the reason that we're here is to find support in each other. So knowing where everybody is at, I think is important. I do also want to point out Perlita Haynes. She is one of our Jett Foundation ambassadors as well. So she's an amazing resource for anybody who needs it. So she's happy to connect, email, phone, all of that. She's happy to help in any way that she can. So I'm just going to go through some slides real quick to tell you more about Jett Foundation if you don't already know. To go over the agenda today, I will present. Then we'll have Vicki Kern, different topic, but talking about flexibility and unlocking the muscles. Then we'll have Dr. Banu talk about respiratory care. We'll have a little break. Then Nicole Hanlon will be talking about palliative care, which I think is really important and not well understood. We will have a lunch break. We will have pharma presentations. I moved the individual perspective at some point. So your agendas are actually up to date, but we'll have caregiver perspectives. Kristen and Kelly are going to speak. And if anybody else wants to speak at that point, they're absolutely welcome, but they're the ones who told me ahead of time. And we'll have a pharma meet and greet as well so that you can, talk to them about anything you choose without having to ask questions with them here up the front. Restrooms, if you don't already know, they are right out to the left, and those are handicapped accessible as well. And then if you have any questions or need anything else, please let us know. Coffee, tea, there's regular and decaf, as well as water in the corner as well. And if at any point anybody has any questions while I'm doing my presentation, just stop me. Happy to be stopped. So Jett Foundation was founded almost 24 years ago by Christine McSherry. I guess it's almost 25 years, by Christine McSherry after learning that her son was diagnosed with Duchenne muscular dystrophy at the age of 5. So it started primarily as a research organization because there wasn't a lot of that when her son was diagnosed, and then turned into a direct service programming organization. That is where the majority of our funds go to. So about Jett Foundation, we do have 4 pillars of support. We have family guidance, awareness and engagement, independence and empowerment, community and education. So our primary mission is to empower people and families impacted by Duchenne muscular dystrophy. However, some of our programs, as you will see, expand out of Duchenne, but our direct service programs primarily are there to support the Duchenne community. So all of our programs support the Duchenne community, and some of them expand out into the neuromuscular community as a whole. So Camp Promise is one of those that I was just talking about that expands outside of Duchenne. We do have now 7 locations across the country. We have next year, our age range will actually change. It'll be 13. It will be our minimum, and we still will have no upper age limit. But we have locations in, California currently, Washington, Arizona, Colorado, Ohio, Pennsylvania, and South Carolina. And then we also have a Connect program. So we have a weekend Connect program that is for those that either aren't able to attend in person or aren't ready to attend in person. So we have that program as well. And we have virtual events throughout the year connected to Camp Promise as well. But what I will say is we have 3 locations that are only for the 18 plus community, which are our California, Arizona, and Ohio locations at this point in time. So those are only for the 18 plus community. So this is one of those programs that is not Duchenne specific, but is also open to other neuromuscular diseases as well. And it's a really impactful program. I actually started as an MDA camp volunteer when I was 16, ended up working for them a little bit, went back to school to become a nurse, and then ended up right back here because once you're in it, everybody says it, but it's a community you didn't want to be a part of, but is absolutely amazing. So I actually worked with Karina at MDA, so small world. So these are just some pictures of Camp Promise activities in the past. Really a truly amazing place, and if it's something that you're interested in or have questions about or are teetering on maybe being a part of, please let me know. I see the head shake over there. All right. Our Jett Giving Fund program, this is specific to the Duchenne population. You do have to have a Duchenne diagnosis to apply for any of these programs. We do have our Accessible Vehicle Fund, which is actually open right now. Applications close on December 13th. But this program is to help families obtain safe, accessible transportation. So families raise half or more of the funds for the vehicle, and then Jett Foundation provides the remaining funds to purchase the vehicle outright for families. So it is only open once per year. It opened on October 28th, will close on December 15th, and acceptances will be granted on January 22nd. It is a very impactful program, but it is a heavy lift program. But if it is something you're interested in, please, again, feel free to let me know, ask questions, reach out. Happy to answer any questions you may have. We also have our emergency fund, which is a rolling application through the year. It is a once per year award, but you can apply at any point during the year. This is grants for families facing emergency situations such as mortgage rent assistance, food insecurity, utilities are our primary, and then there's an other category. So if at any point you feel like you're in emergency need and it's not within one of those categories, please still fill out an application. We do have a committee that reviews it. We can turn it around. We've turned around things within a day to help with eviction, things like that. So please, if you need it. I know this is something I hear all the time, is that, people need it more than I do, and that's just not true. An emergency is different to everybody, and everybody needs help. So if at any point you feel you're in that situation, please reach out. We also opened our equipment assistance fund last year. So this is financial assistance for small accessibility and medical equipment either not covered by insurance or too expensive of a copay. So we've paid portions of a copay for customized wheelchairs. We've also paid for what I call the chair before the chair, for when that transition between ambulatory and non-ambulatory is happening, but you're not quite ready for the full power wheelchair yet. Those travel chairs that can also help with, traveling, not just the mobility piece. We've helped with those pieces of equipment. It is a max grant currently of $2,500, and it is rolling, but again, a once per year award. And this is Darnita and her son, Lido. They were recipients of our VAN program in 2023. And then we have a quote here from a family who received emergency assistance. It really is a very impactful program. So we do have our community ambassador program. As I said, Perlita is a part of it and has been for quite a while. She's an amazing resource. And anybody is welcome to become a community ambassador. Our goal is to have one in every state, because resources are so different per state, per county, per city, all of that. So the more ambassadors we have, the better resources we have for families. So these are also our eyes and ears on the ground. So our webinar series, which we'll talk about next, we actually pull information from what's needed in the community. Like we just had a webinar on fatty embolism syndrome, which Perlita was part of, and that was fully because of the need for knowledge in the community. So they're the ones really bringing those to us and trying to share that information with us, but they're also the people that we're connecting newly diagnosed families or new families to us that would like support and guidance. We're connecting them as well. Community webinar series, like I just said. So this is also a way we try to expand out of Duchenne. Our webinar series has to be applicable to Duchenne, but we do try to focus on rare disease as a whole. But we've had topics such as, these are a little outdated, but Social Security. We have one on service dogs coming up in January. We've talked about some generalized things, but we do have specific ones like respiratory care and Duchenne. Driving was more general, but we do really try. We have coming up November 21st, Solid is doing a webinar. December 6th, we're actually the process of getting a service dog. And then all of these webinars that are upcoming are on our website, and as we add them, they'll come on our website as well, so please feel free to go on our website and take a look. We also have our family support groups. So Porch Night, which Perlita helps facilitate, is one of them. We have them currently bi-weekly. every other Monday, and we also have in-person porch nights. We actually had one in Harrisburg in October. And then that is a group for female caregivers to just come together and talk about their journey and what they need. And it's not all Duchenne-based either. We talk about, what's going on in life and the best Netflix movie and all of that. So it's not just Duchenne-focused, but it is a great pillar of support. We also have Carrier Conversations, which Trina Stelly, who is one of our resource specialists, facilitates. And that is for female carriers to talk about their needs and what they need and the care that other people are getting, because I think it's a topic that there's still a lack of knowledge about. There's no standards of care, anything like that. So talking about where to get care, what to do, what questions to ask. We created a journey to diagnosis and next steps for female caregivers. So that is a really great community. Caregiver Connection is a program that we have for caregivers to a female impacted by Duchenne. And those are once a month. Carrier Conversations and Caregiver Connections are currently once a month. But if you have any questions about those, please let me know. But again, they're great support systems. And so all of our programs are listed on our website and our social media. So I definitely encourage you, if you are not already, to connect with us either through Facebook, Instagram, Twitter, which Twitter, whatever we want to call it now, LinkedIn, and our YouTube channel actually has recordings of all of our webinars. It also has recordings from past workshops. So, it's important to get the education in those communities, but other communities are also able to get that education as well. I do want a huge thank you to our sponsors. A few of them are here today, but we could not do it without them. So this is a list of all of our sponsors for our family workshops in 2024. And then we do have these throughout the year. We go to different places across the country. We have we just came back from Portland. We're here, which we're very excited about. And then we have 2 springs confirmed for Iowa City and Birmingham, Alabama. So some families come to more than one, especially because, the topics tend to be different. But if you do know of any families in those areas that are interested, please feel free to let them know. And thank you for joining us today. Like I said, we could not do it without you. And with that, I will stop talking. Does anybody have any questions? All right, if you do, please find me somewhere. And with that, I will hand it off to Vicki. I'm going to be right here in case you need me.
Okay, I'm going to put my extra notes over there. Hope that works. Hi, I'm Vicki Kerner. I'm a physical therapist. I want to thank Perlita for roping me into this, and also Paula Cameron, my nurse manager, who could not be here today because her son's getting married, so yay for that. I'm going to say right up front, I am not tech savvy, so be prepared for there to be glitches in what I'm doing. For instance, advancing my slides, love. This little button? Okay, cool. So the arrow button, that's the one. It's not my tech, so I don't know. So we're going to kind of skip over this just because it's not really important. So I know that on your agenda that you received initially, it said we were going to be talking more about the caregiver, right? And now you see on your program, it says unlock the muscles. Well, we're going to blend those 2 topics because we just had a little miscue. We kind of missed each other a little bit. So we're just going to blend those 2 concepts. So what I really want to talk about is routine-based flexibility strategies. And this is a concept that kind of blends my backgrounds. I have been taking care of kids with Duchenne's or with any kind of neuromuscular disease for about 30-some years, more than I care to count. I also do early intervention, which some of you may know is taking care of very young children using a coaching model to help parents to embrace and embed appropriate strategies to support their child's development in the 0 to 3-8-year-old population. So it came to me the other day that I had a day when a bunch of guys showed up to my clinic, slightly older guys, in their late teens or early 20s, and just like 5 guys in a row all said, my feet hurt, my neck hurts, my back hurts, my hips hurt, and I was like, what is going on? And it really struck me that what was happening was they were getting stiff. And the stiffer they got, the harder it was to position them, to care for them, to transfer them, to get them clean and dressed and all of those things. And these are basic necessities, right? This is what you do all day long. And so because it was very difficult to overlap that with stretching exercises, the stretching doesn't happen. And so we get stiffer and stiffer over time until now they were presenting with pain, and I had no real good remedy. Nobody is going to do orthopedic surgery on our guys' feet to get them back to being flat on a foot plate, right? There's just too much risk. So what do we do about this? So the answer, in my mind, is that we need to embed strategies about flexibility into our daily routines. This is what we do in early intervention, right? You want your kid to learn how to walk, so I tell you to move your coffee table 3 inches away from your sofa. So he can go from sofa to coffee table, and eventually he's got to take independent steps, right? You didn't do anything but move your coffee table. This is the way we need to think about flexibility. So, oh, you made them so that they loaded. Nice. Apparently you did. But everybody needs to be flexible, right? So you as a caregiver also need to be flexible and strong, because how many times do you come into my clinic holding your back or your leg or something? You're like, oh, because you're stiff from all the lifting, all the twisting, all the torquing. And so really this flexibility is about everybody. All right, just some disclaimers. Be aware, yes, I'm a licensed physical therapist. I am not individually evaluating all of you and your children today, so take everything with a grain of salt. Please practice some of these strategies, but if anything hurts or whatever, go to your primary PT, go to your primary care doctor. And just some disclosures, I'm really not attached to anything or anybody at any time, really, professionally speaking, except to maybe Perlita, I don't know. So some goals for today. We want you to be able to understand how to embed appropriate exercises, movements, and activities into your daily routines so that you can maintain flexibility or attempt to regain flexibility. And we want you to have a reusable resource that you can go back to over time, because your situation is going to change over time. All right. So we understand there's stages to walking and stages to sitting, right? And so we can see that over time, the body changes in response to the changes in the muscle. We know that we want to allow boys to be compensating for their weakness to keep them walking, right? You're not going to put braces on a kid walking to keep their feet flat because they're going to fall. We let them walk however they can walk so they can keep walking. But we need to make sure that we're not letting go of the flexibility they need in those joints. We've got some research that's emerging. It's a not well-researched topic, but there's more and more data coming out showing that the loss of ankle range of motion can negatively impact your ability to walk, the speed at which you walk, and your ability to get up off of the floor. We have a large bank of data coming out of a relatively old trial now. The 4DMD trial is still processing a lot of its information, and some of that information will relate to the ability for night braces to really make a functional difference in your ankle range of motion. So we know that as we get contractured into different positions, this is affecting the posture, right? It's affecting the way you sit. Now, I'm looking around the room and I'm going, I want every single adult here to sit up straight. You know, you need a little lumbar roll, right? I saw you slouching. If you don't move your position, you get sore, right? So you kind of do this, or you scoot onto one hip, or whatever. You keep moving. Our guys have trouble with that, right? And so they're kind of stuck in one position. But let me tell you what their chairs can do. Their chairs can tilt, their chairs can recline, their chairs can put their feet up. Their chairs can do a lot. But you guys don't move your chairs much, right? Because sitting upright is a very functional place to be. So we need to make sure that we're maintaining the ability to be aligned properly so that they can do what they can do. Drive their chair, use their hands, right? They need to be able to do that. If they're stuck in one position, that's going to become inefficient over time. Okay, so when we talk about trying to stay stretched out, these are the areas in which most of our guys get stiff over time. So ankle dorsiflexion is that upward bending of your ankles. Everybody kind of know what that is. It's the opposite of being on your tippy toes. Okay. Knee extension, it's pretty self-explanatory. It's getting your knee all the way straight. Your hamstrings contribute to your knees not wanting to go straight, but your knees and your hamstrings are two different things, and they need to be stretched in slightly different ways. Hip adduction. This one is kind of tricky, so I'm going to show you. We'll walk away from the mic. I usually talk loud enough. I don't need a mic anyway. So this is hip adduction, right? So that the leg travels across the body. There's a culprit to getting rid of that, which is this big old IT band on the side of your thigh. And when that IT band gets tight, it pulls your legs out to the sides. This is a very chronic problem for a lot of our guys once they start to sit. Their knees get wider and wider. What else has to get wider? The chair they're sitting on. The wider my chair, the less maneuverable my chair is, the wider my doorways need to be, everything gets more complicated. And that's not something we think about a whole lot. It also creates pain syndromes at both ends of the muscle, down by the knee and up by the hip. The tendon itself can become inflamed when it's under too much tension chronically. Spine and hip extension. So if you're sitting all the time, you tend to kind of slouch, or you kind of go a little sideways, or you might be one of those people that sits really forward, has a big old arch. Wherever you are, you can get stuck there if you're not moving enough. And your hips, of course, are sitting at a 90-degree angle all day long, and then they bind down very quickly. Then the wrist and the forearm, we don't often think about that a whole lot. This is the most functional position of your hand. If I had to have my hand stuck somewhere, I want it stuck this way because I can type, I can grab, there's a lot I can do this way. But the loss of this can also compromise the way my hand can function for me, especially for things like bathing and dressing. We want to make sure that everything can move so that it doesn't become difficult to get a sleeve. Like try to get a long sleeve shirt and then a winter coat over a hand that's stuck in one of these positions. It's really tricky. All right, so we're going to get into the nitty gritty. Now, if we talk about ankles, we know we want that upward bending because all the forces are pulling into that toe down position. Using something like one of these standing boards, you don't even have to buy something, right? I'm all about make it yourself because I'm cheap. I'd like to say thrifty, but cheap is really what it is. So an old phone book, an old book, if you don't read books anymore, just tape the phone book together till it's a block. Get a piece of 2x2 from the Home Depot that is only a couple feet long, or from your backyard if you live in a place like mine. You just need the toes to be up and the heel to be on the ground and the child leaning forward into some kind of table, a counter, anything. And the kid can stand there and do their homework. They can play video games, right? Their favorite thing to do, play video games. Just have them stand there for a few minutes. That is worth more than me trying to range their ankle 100 times a day, which I don't have time to do anyway. Now, effective stretching with your hands is extremely difficult, right? That guy in the blue shirt, that's a therapist, and he's demonstrating the way we teach you to stretch your ankles, right? But the ankle wobbles in and out because it's trying to get away from the stretch on that big tendon in the back of your calf, which is the problem. So you can wobble out just a little bit and you're not stretching what you think you're stretching. You could wobble in a little bit, same problem. It's very difficult to keep that foot right where it needs to be. And how many kids do you have that are going to relax and let you stretch their legs? Not a single hand in this room is going to go up, right? Because they're going to push against you. That's natural. You push on me, I push back. So it really is not a terribly effective way of gaining range of motion. This is a much more effective way, but the braces don't do any good if they're in the bottom of your closet because your kid doesn't wear them. Right? This is one reason why we're drawing some information out of the 4DMD study to really look at reported compliance with bracing prescription to find out, are people really wearing these? Because I can't tell you how many times I order braces like this, and they come back 6 months. Did you fill the script? No. Why? I didn't think it's necessary. Give him a script again. 6 months later, you wearing the brace? Well, we got them, but he doesn't like them, so we just don't use them. Now my kid's up on my tippy toes, and now I've got problems, right? I like to start these really, really, really young. And with our new neonatal panels, and we're getting kids identified much younger, I can have a kid walk into my clinic at 2 or 3 whose ankles look great. I'm still ordering these. Because the earlier I start, the more likely it is that the child is going to learn how to sleep in them. Now, did your kid learn to brush their teeth by themselves? No. You had to teach them, right? You have to teach your kid to sleep in these. Right? So if your kid's old enough, you reward them in the morning. Oh, your braces are on. Good boy, you get a sticker or whatever. And you start with an hour at night. Oh, you did your hour. Great. You can have a sticker. You can get so many stickers. You get more time on your Xbox. Right? Technology is here for us to use. The only reason my kids got Xboxes or phones was so I could take them away and use that as my motivator, right? That they got to be motivated. They don't know why they're supposed to do this stuff. There's a variety of designs. You can start with just an hour or 2 with the child sitting on the sofa with their feet propped up and they're watching a movie or whatever. You advance it gradually. We're not expecting any 2-year-old to sleep in these all night long, right? But you as the parent have to teach them that this is what we need to do, that by the time they're 6, 7, 8, 9, 10 years old, it's automatic. I just sleep in my braces. That's what I do. if your ankles are already tight, do not panic, okay? This does not mean that it's not possible to address the ankle issue. What happens is we never really think about the way somebody's feet are on the footplate of their chair until they have a problem. And their feet have turned, and now all the pressure is on the outside portion of the foot, which is not meant to bear weight. The outside of your pinky toe is not meant to have the weight of your leg sitting on it, right? That's meant for the bottom of your foot. And so what happens? They get calluses, their feet hurt, so you're putting pads on, you're putting air cushions on, you're putting them in different kinds of shoes and slippers, and it's not addressing the bottom line issue is you got pressure on a part of the foot that's not supposed to have it. So how do we address that? If you have a foot that's stuck in 40 degrees of plantar flexion, set your foot plate at 40 degrees of plantar flexion. Because then I'm not resting just on the toes, allowing my feet to roll outwards, right? So if I'm just on my toe, I have to use thigh muscles to keep my foot from doing this. If I don't have muscles in here to do that, gravity takes my foot out to the side. Now I'm on my pinky toe, right? So what we want to do is just accommodate the plantar flexion to avoid that turning where we end up with the soles of the feet looking at each other. Now, your foot's on a little hill. It's going to want to slide off. Okay, so I can put anti-skid stuff. I can put a little bumper at the end. I can put a little strap anywhere. I can do anything. But if I keep pushing that foot upwards when it can't go, it's just rolling out, and now not only are my feet looking at each other, my knees are way out here. And now I'm back in that big wide chair. I had a couple boys roll into my clinic. Bless their little hearts, they're adorable. They literally have like 12 inches of seat depth because their legs are so wide that there's no way to push them back into their chairs any further than that because it's from here to the edge of my knee. Well, if my knee's way over here, that distance is very short. And they're barely sitting on the edges of their chairs. Okay, so let's talk about knees and hamstrings for a second. Like I said, your knee is your joint. Your hamstring is the muscle of the back of your thigh. You can, for kids that can get down on the floor, have them sit with their back up against the wall, give them a little, one of those little bed table thingies, and they can do their homework. They could do puzzles. They could play on their tablet. They could, write War and Peace. If you're in a chair, you just stick your feet out. Stick your feet out, Javian. Javian's my bud, so. He's the friendly face that's in here for me today. So this is Levi, everybody. And so all you really have to do is periodically put your feet out, and you're at least doing something with your knees and your hamstrings, right? How many times a day? I don't know. There's no real recipe for that. But how many times do you change the position of your legs since you've been sitting here, right? More than we think. So I can't remember anything, right? Perlita will attest to this. I can't remember anything. So I have my watch. Love my watch, addicted to my watch, because it buzzes and says, it's time to take a breath, Vic, or it's time to pray, or it's time to go for a walk, or it's time to get up and move, right? You have all those fitness things in your watch or in your phone. What kid in here does not have a phone? This one, right? He doesn't have a phone yet. Thank God. Thank you, Jesus. No phone for the baby. Hi, buddy. You're adorable. He has a tablet, though, doesn't he? Can you put an alarm in his tablet? You sure can. But older guys, they have their phones. Put an alarm in there that says tilt or elevate or change, whatever reminds them to move their chair. Okay. The other thing that you can do is you have to help your kid get dressed at some point, right? There's going to be a time in their lives where you're really doing their bathing and dressing for them. And so you could add maybe 3, 4, 5 minutes to your dressing routine once or twice a day to take those limbs through their whole range of motion. I'm already picking up your leg to get your pants on, right? I might as well just go all the way up in the air and count to 10 and bring it back down again and then finish putting your pants on. It doesn't add that much to a routine you're already doing. Now, I'm going to say something. Peanut butter. Raise your hand if you thought jelly. Thank you. I got one. Yep. Because peanut butter and jelly go together, right? How do you learn a new habit? You attach it to something you're already doing. So if every time you get your kid dressed, you think to bring their leg up like that, you're doing their hamstrings and their knees. You've already attached it to something you have to do. I don't want you to think of stretching as something extra. I want you to think of it as modifying what you're already doing in order to make that effectively kill 2 birds with 1 stone. Got his pants on, got his legs stretched. got his shirt on, got his arms stretched, right? Okay. So this is this critical muscle I was talking about, the IT band, the iliotibial band. There'll be a test later. So it's really critical to your leg alignment. And your legs and your pelvis, or your hips, are the foundation of your sitting posture. So if you come into my clinic and your head's kind of funky and you're like, my neck gets stiff, my neck's sore, the first place I look is your hips and your pelvis, because that's what I'm stacking your spine on, and that's what I'm stacking your head on. So if something's wrong at that base, I can't fix what's up here with all kinds of pads and pieces and straps and whatever. That's not going to help, because fundamentally we have a problem. So legs start to get wide, feet start to roll out. What does your pelvis do? Everybody do this. Move your chair so you can put your knees out really, really wide. And tell me what happens to your low back. Come on. I'm a physical therapist. I have to make people move. So put your knees out really, really wide. What happened to your lower back? Went backwards, right? Mm-hmm. Now you're going to sit like a shrimp. Tell me how long you can sit with your spine curved like a shrimp before your neck starts to hurt, or your tailbone. Right now, some of us have a good amount of padding back there. Some of us don't, right? And if I don't have good padding back there, just that little bit of motion is going to make me sit on my tailbone, which is going to get sore and may end up with an open wound. And, right? And it just comes from pressure. Then put that posture in a chair that's never changing its position, even though it can. So we have this constant pressure. And what we need to do is stay flexible enough in our hips that our knees can stay in line and give us a nice solid foundation for our spine. And how are we going to do that? We're going to do that by doing these different positions during the day. Okay. Whoops, let me back up a second. So see the kid with the striped shirt sitting with the knees really wide, and the kid with the hoodie on with the knees really tight? Okay, I'm not saying that your kids have to have their knees nailed together or duct taped together for the whole day. But if you put a strap around the end of the thighs right above the knee, and they wear that for 10 minutes, 15 minutes at dinner or while watching TV or playing Xbox, that's all you need to do. You don't have to do anything necessarily except apply the strap and then take the strap off. It is really nice to do this in a sitting position and also in some extension. So maybe it's something they do in the morning eating breakfast sitting in their chair, and then again at night right before bed, or when they're chilling out on the sofa or wherever they are, where they're in a little bit more of extension, because it affects the muscle differently. But if you think about counteracting the forces of the disease is robbing strength, it's causing tightness from position, we're going to fight that piece. Does that make sense to everybody? Okay, perfect. So, standing frames. There's some debate. I guess you wouldn't see debate in the literature necessarily, but the usefulness of standing frames. So I can't tell you how many people I know who have standing frames that they're using as a clothes horse, or it's just collecting dust in a closet. They're cumbersome, they're expensive, they're a pain in the behind, honestly, to get your kid in and out, and it becomes that extra piece, right? We're trying to get away from extra pieces because your brains are so busy with everything else you have to do. I don't want to give you something else you have to deal with, right? I want to simplify by being efficient. Now, part of our problem is to get a standing frame attachment onto a power wheelchair, at least in Pennsylvania, not easy to do. Is it worth the fight? I think so. I'm starting to wonder if Jett might help us with this a little bit. I don't know. Unpaid for. Meet me halfway, sister. So what happens is some people, they'll roll into my clinic. Their kid hasn't been standing for like a year. They maybe haven't been doing a lot of positional stretching or range of motion or whatever. Now their kid has contractures at the hip, the knee, and the ankle, and probably developing osteoporosis. And now they want to go back to standing. I hate to say it's too late, but it might be too late, because we have to understand just a little bit about the forces of gravity. So, back again I go. If my knees don't go all the way straight, and my ankles don't go flat, hang on, I gotta hold on a second. Now I'm gonna try to stand like this. In order to do this in a standing frame, I've got a pad here on the top of my tibia. I've got something behind my butt. I've got something on my chest. And I've got something under my heels, right? Which way is gravity going? Gravity doesn't do this. Gravity does this. going this way. It's going like this. So what happens in an osteoporotic femur? Snap. So if I need to stand, I cannot have more than a 30-degree knee flexion contracture. I have to be able to get my feet relatively flat, and it doesn't matter if they roll in, just relatively flat, and I can't have more than a 30-degree hip flexion contracture. That's here. If I can get to here, I can probably stand passively and be pretty safe. But if I can't get here, if I'm like this, it's off the table. And you're looking at major orthopedic surgeries to try to get back to here. How do we stop that? We stop that by having our kids fully extended in any position to keep them, what's the magic word? Flexible. Okay. Oh, that came through really loud. All right. So I think, honestly, that we probably need to do standing options on the first chair the kid gets. I think we need to also counter that with some other positions we're going to talk about in a minute. So leaving the legs for just a second, let's talk about your arms and your spine for a minute, because I'm a PT. I do think mostly about legs. I'm sorry. But I work with some fantastic occupational therapists. And one of the problems that occurs is that if your arm is stuck in any one given position, regardless of what that position is, really hard to get dressed, right? If I can't get my arm up, I can't get my armpit clean. If I can't get my arm up, how do I get it through a sleeve? Like, you guys know, it's hard. So let's make it easier. When I go to put the shirt on, it just takes 2 extra seconds to take that arm all the way out. 2 seconds, maybe a minute, okay. Just to bring that arm all the way out, all the way up. Wrists and forearms, kind of mentioned this a little bit. This is the most flexible or most functional position of your hand. You're gonna get stuck anywhere, get stuck here, which is where they get stuck. But if we can avoid getting stuck, why not? Let's get their hands palm up. So kids can do this to themselves. They never remember. It's fine. But let's say they're sitting in their bath chair and they want to do some body washing while you're doing their hair. This is how I put shampoo on my hand, right? So turn the palm up, put in the soap. They can be doing their body. You're doing their hair or whatever. If they're still walking and they're safe, like maybe not, little man over here is probably not safe enough to carry his dishes in from the kitchen sink, but if they can carry something on a tray, can they still carry their tray at school from the cafeteria? This way, not this way, this way, right? This is stuff you can write into an IEP, by the way. Position changes in the chair, carrying their tray with their palms up. Literally that detailed. I used to work in a school. Yeah, that's what I'm going to write in their IEP. So that if they have an aide, they have a therapist, somebody's keeping an eye that they're following those strategies. The school has to do that. So you can embed stuff in school. He's so cute. And we see our friend Levi doing the prayer stretch, right? He could be sitting here watching an instructional video for his homework, not playing Xbox or watching, I don't know. What does he watch, Perlita? Junk on YouTube? I don't even know. He's a good boy. Phillies, yep, he could be watching the Phillies game. And he got himself into that position. I said, Levi, I need you to do this on your desk. He said, okay. And he went over and he did it. I'm like, yay, Levi. Right? Just a couple of minutes. Doesn't have to be forever. Our bathing and dressing routines. You're going to wash your kid's hand, right? You wash the little man's hands, right? He's not going to do it himself yet. So turn his palm all the way up when you're doing that. Get the wrist to come back. Get the wrist to go this way. You're manipulating him anyway. Do it then. Same thing with the shirt. We talked about that a little bit. I love this little guy putting on his boot, right? He's like, I'm going to get my boot on. But one leg is completely straight and flat, and the other leg is bent. And that means that straight out leg, that's getting some nice stretch on it. Okay, elbows. I said, Levi, I need you to just drop your arms. He said, okay. He just dropped his arms off the side of his chair. He doesn't do that if I don't ask him to do it. All he needs to do is let his arms hang, and he's getting out of this and getting into that, so that those elbows get straight. It's gravity, right? Gravity is a killer, but gravity can work for us. So ways to try to get those arms to just hang down the side, right? If it's really stiff and you're like, oh, I really want to get that back, sure, you can lay your arm out on a countertop. You can do like a little weight over your hand or something to just get some passive stretching like this on a table. It's not a very functional position, but again, if they're watching something, not playing something, that's fine. Just get those elbows out. Hip and spine extension, right? So this goes back also to the IT band piece. You can stretch it when you're sitting, but this is not a position our guys get in, right? Him, yeah, sure. We can put him on his belly. That's easy, because I'm bigger than he is. But If we get him on his belly now and keep him laying on his belly for a really long time, over his lifetime, then it gets easier to keep it than it is to recover it. So even if the girl on the yoga mat, she's got a towel roll under her hips, she's got a pillow under her chest, you could even put a kid over a body pillow so that you're taking away some of the stress of the position. But what you're doing is you're stretching their spine, you're stretching their hips, you're stretching their rib cage and their diaphragm, which is going to make it easier for them to keep breathing deeply. That's important, right? Dr. Binu, is that important? Yeah, we work together. So just changing your position also helps your bowels to function. If you have any problems with constipation, your bowels are a three-dimensional puzzle, and so when you rotate it in space, now gravity's working a little bit differently, plus you have abdominal pressure from being on your belly, really helps with your bowel function. So for little guys that are getting up and down off the floor, no problem, this is pretty easy to do. As they get older, they're going to get stiffer. It's going to be more difficult. We may need to find other ways to get into extension. Back to Levi. So look at what that chair can do. The only thing he's not doing is laying literally on his belly, but otherwise he's in the same position, right? Now, when he drops his feet down, he's now really stretching the front of his hips, his quadricep muscle, that big muscle in the front of your thigh. He's stretching his knees because now the thigh muscle is really pulling across the top. And he could lay like this for 3 to 5 minutes, right? He could listen to music. He could do something just because. And he could do it during school because you write it in the IEP. Okay, so our take-home messages. Flexibility really matters. It matters to avoid pain. It matters for function because we need to keep our posture so that we can be as functional as possible. Flexibility is easier to preserve than it is to recover. So start now. Wherever you are, it doesn't matter whether you're already stiff or you're not stiff or you're little or you're big, it doesn't matter. Start where you are and preserve what you have. Flexibility can be maintained during daily routines. It's not rocket science, but it's thoughtful, it's intentional. It's taking something you do kind of automatically and intending to embed in it something that's just a little different so you can kill 2 birds with 1 stone. And flexibility unlocks your muscles. We're all about muscle strength, right? This entire community is about preserving, recovering strength. What good does strength do you if your joints don't move? Okay. That's a little QR code there. You can scan that. It will take you to the Jett Foundation website where you will find a home program that includes pictures and descriptions of how you can use these different positions throughout your daily routine. So I'm going to leave that up there for a second if people want to snap that or do whatever you do with a QR code, because again, challenge. I couldn't even create the QR code, FYI. Alexa had to do it. Yeah. I tried. Points for Vicky. I tried. Truly, I tried. Yes. Well, I asked. Please, can you help me? So I was very excited about that. Okay. Is everybody good with that? Okay. I just want to say thanks. I want to say thanks to Levi for being my model. He's such a good sport. I was like, Levi, do this. Okay. Levi, do that. Okay. Levi, smile. He was hysterical. And to Perlita for her amazing support of everything we do at Penn State. Paula Cameron is the best nurse anywhere. She's the nurse manager for our clinic. I did quote some of the research, and that's just a sampling of some of the research that I looked into. And obviously some of my pictures and things came off of Warner Brothers and also off of Google Pictures. And that's Levi and Eclipse, his assistant dog. So love them. All right. You got a question? You have a question for me, sport? What are you doing? Are you doing a puzzle? I like your puzzle. I like the zebra. Are you doing the elephant? The elephant. Are you shy? It's okay. You're adorable. You're like going to be the adorable guy everybody remembers from today. All right. Thank you guys so much. Appreciate your time.
If anybody does come up with any questions that they think of after the fact, I can definitely get them to Vicky and we can get them answered. So if you are processing and leave and are like, oh, I have questions, we can definitely make that happen. All right. And next up, we have Dr. Banu.
My name is Binu Shankorkal. I'm the pediatric pulmonologist that primarily works with our Duchenne patients at Hershey. So I was going to be talking about respiratory care in Duchenne muscular dystrophy. So in terms of objectives, so some of the things that, which you probably already know, most of these, we just wanted to talk about, some of the basic things that the lungs do, kind of see how lung doctors will assess the lungs, and talk about how the cough assist machine works and helping to get secretions out, and then understand why we might get a sleep study, and then ways to treat sleep apnea. And then also to understand why, if we end up needing to use positive pressure, why bilevel therapy is better than CPAP therapy. So the lungs, and all of you know this, do two main things. So one is it gets oxygen into the body, and so you get oxygen into the body by taking a breath, and that takes muscles to get air into the lungs. There are two main muscles for breathing. There's one called the diaphragm, which is this dome-shaped muscle that pushes the abdominal contents down and forward so the lung expands downward. And then there are also skeletal muscles called intercostal muscles that kind of help the ribs to flare out to get air in. Then, so air gets into the airway, it passes through the lung tissue and then into the bloodstream. And then the other main part of what the lungs do is to get rid of carbon dioxide. So your body's making carbon dioxide, and then you'll exhale out what the body makes. Breathing out is a passive process, meaning you don't actually have to use muscles to get air out, but it is dependent on how much air you bring in. So if you take small breaths, then you breathe out smaller amounts of carbon dioxide. So bigger breaths tend to then get rid of more carbon dioxide. And then the other main role of the lungs is to essentially help to get stuff out of the lungs. And so the lungs are really open to the environment, that the nose and the mouth filter some of the things out. But we end up having things that enter the lungs. So particles kind of get trapped in mucus. Infections can get trapped in mucus and also can get killed. But whatever is in there in the mucus, we need to get out. And so that takes a cough, which takes muscles. And so you get an irritation in your lungs. You start to breathe in, you close up your vocal cords, you build up pressure, and you get it out. So the coughing part and getting air into the lungs takes muscles, which as patients with Duchenne get older, can get weaker and not quite clear out secretions as well. And so if you don't cough as well, this can lead to illnesses that take a long time to get better. We could end up needing to use antibiotics, and then in more significant situations, we may need to even have a patient get hospitalized just for some increased treatments. So this slide you don't need to really look at, but this kind of summarizes really what lung doctors do, which is when we look at how strong are the breathing muscles, how strong is the cough, and then what can we do about that if the muscles aren't quite as strong. How is the patient sleeping? Do they have good quality sleep? Is the lung doing what needs to be done when they sleep? And then also how are the oral muscles, how are they doing in terms of getting things safely into the stomach? I'll mostly be talking about muscle strength and sleep in the next several slides. So in terms of lung doctors, so what we would assess when we're talking to you would be essentially, is your child having any difficulty breathing in general? Like, do they seem like they're uncomfortable breathing quickly, struggling to breathe? One of the things that's helpful for us is knowing if a patient can walk. So if a patient's able to walk, that generally says that the breathing muscles are pretty strong. Once we get to a point where a child is needing to use the wheelchair most of the time, that would tend to say that probably the breathing muscles are also getting a little bit on the weaker side. And then, like I had mentioned, we want to get an idea of how kids are doing with cold viruses. So are they getting better in a week and a half, or is every illness taking 3 or 4 weeks to get better? That could be a sign that maybe the muscles are a little bit weak. They're not doing as good of a job clearing mucus, and so it takes longer to clear the infection. Or if patients are needing antibiotics or being diagnosed with pneumonias frequently, that could also be a sign that maybe the breathing muscles aren't quite as strong. And then subjectively, we can also see if patients are having a lot of coughing, and then also trying to get a general idea if the cough does the job. Like if there's mucus in the chest, does the mucus seem to clear out with the cough? Is the cough strong enough that you can hear it in the next room, or do you have to be sitting right next to the patient to hear it? And then other things that we talk about is a little bit more of the GI stuff. So From our standpoint, we like patients to be stooling regularly. If your abdomen is sort of full of poop, that makes it harder for your diaphragm to push down and do its job. So we'll often just want to make sure that kids are pooping relatively frequently. And then we'll also get some general idea of how swallowing is, if there's any difficulty getting food down, if it seems like somebody's coughing or choking every time they drink, then we may want to better assess the swallow by getting a swallow study. Difficulty swallowing tends to be a little bit later thing, so more in the 20s rather than in the younger age groups. So these are things that we would tend to assess when we're talking to families and our patients. And then on exam, some of the things that we'll look at. So for the vital signs, the main thing that we'd be looking at is breathing rate and oxygen levels. We're looking to see if we can get equipment to measure carbon dioxide levels in the office, so that can also be helpful to assess. And then looking at our patients, so sometimes we'll look in the mouth to see if the tonsils are big, especially in patients who have sleep apnea. And then also we can look at the back of the mouth to see if there's some anatomic changes that might make somebody more prone to having difficulty breathing with sleep. And then we just look to see, is a patient comfortable with breathing? Are they breathing quickly? And then when we listen to them to see if there's good air movement. Sometimes if muscles aren't quite as strong, it may be a little bit harder to hear breath sounds. Or sometimes we may even hear the sounds of mucus in there to see if we need to be more aggressive with getting mucus out of the chest. The neurologists do much better for this, neurologic exams than I do, but one of the simple things that I'll ask is just asking for a patient to lift their arms up. If they can shoot their arms up over their head, that would tend to say that their breathing muscles are pretty strong. And then if you can walk like him, that also says that your breathing muscles are pretty strong as well. And then we check, just how well the blood is flowing to the fingertips, just how they're perfused. Some of the more helpful assessments are the breathing tests that we have on our kids. And so we'll do spirometry on our patients, which is essentially, I think you've seen that our patients do them. They'll take a big breath in, they'll blow out hard, and then we'll get some different information. One of the main things that's helpful is the measuring the forced vital capacity. So that's how much air that a patient blows out. And so we'll compare that to a typical boy of that age and height, and we'll get a percent predicted. And so that kind of helps to see where we are relative to other kids. And then we also use it to trend over time. So typically as kids get older, the number gets higher and the percent predicted stays stable. And then sometimes as kids are starting to need the wheelchair more, that number kind of levels off. And then in older age, the numbers can start to drop a little bit. So that's a really helpful measure to get an idea of lung size and how the disease is progressing in terms of the breathing muscles. And then, like with any patient getting spirometry, sometimes we can see if there's signs of asthma, which we may also then be treating for our patients with Duchenne. They would be at similar risk to any other patient of having asthma symptoms. And then we have specific tests of muscle strength, which will also trend over time. So we'll measure how strong someone can breathe in, which is the inspiratory pressure, how hard they can breathe out, which is the expiratory pressure. Sometimes it's a little bit hard to make a good seal, so we sometimes have leak, and so we'll need some help to decrease the leak, oftentimes with parents. And then we can also objectively measure how strong the cough is. Usually we look for a number of 270 liters per minute or higher. We know that kids with muscular dystrophy get weaker when they're sick, and so if a cough is this strong when you're well, then it would tend to say that your cough is going to stay strong enough when you're sick. And then in terms of other ways to assess the lungs, so sometimes we'll get some blood work. We'll check a chemistry. So for us as lung doctors, we tend to be most interested in the bicarbonate. So if a patient's holding on to carbon dioxide because they're not taking big enough breaths, the kidney will then compensate by making more bicarbonate. So if that bicarbonate is high, that might tell us that the lungs are not quite doing the job that we would be hoping. And then sometimes we'll get a blood count, and we'd be looking mostly at the hemoglobin and the hematocrit. That can give us an idea of if the oxygen levels are chronically on the lower side, sometimes we'll see that those numbers are higher. And then we'll also get a blood gas, which helps us to actually measure the carbon dioxide level, which helps us to see, how well the lungs are doing their job. And sometimes we'll also get x-rays, chest x-rays we get periodically. It helps us to get a visualization of how well the lungs are inflated. We can also see if there are areas that aren't getting as much air and they're getting a little bit collapsed, called atelectasis. That may help us to be a little more aggressive with some of the treatments that we would want to do. And then anybody who has weakness is more likely to get scoliosis, and so we'll sometimes get scoliosis x-rays, which obviously the orthopedic doctors would be helping to more actively manage. And then if we find out that the lungs are a little bit weak or a little bit on the smaller side, there are some things that we would start to do. So typically, once that FVC is about 60% predicted, we'd recommend different maneuvers to help to inflate the lungs. And some of the ways that we'll do that, so just breath stacking. So when you're sitting watching TV, you can take a breath, don't exhale, and then take another breath on top of it, and then another on top of that, so that your lungs are more inflated. And then you just hold that for 5 or 10 seconds. And then like with some of the stuff with Vicky, there's no right amount of time to do it, but the more times you do it, probably the better. Sometimes patients will have bags where you can actually physically push air into the lungs. A lot of our kids don't have the bags at home, but many of our kids have the cough assist machine, and you can use that to essentially use it only on the inhale to reinflate the lungs. And so these are horses' lungs. I didn't realize they were so large, but they're impressive. And so if any of your kids' lungs are that enlarged, we've gone way too far. And they're horses apparently, horse lungs. And then we also like the lungs to be inside the patient. So, and so other things that we can help with for patients, in addition to helping keep the lungs inflated, is once the lungs get a little bit weaker, so the FVC is about half of what we'd expect, we may want to be a little bit more aggressive in helping to clear out secretions as well. So once kids have sort of the lower FVCs, we'll recommend doing routine airway clearance, which will typically consist of using the insufflation, exsufflation, or cough assist, which I'll talk a little bit more about. Sometimes we'll have kids who have perfectly great strength when they're healthy, but when they're sick, it seems like every cold is hitting them hard. They're taking 3 weeks to get better. They're needing antibiotics. So sometimes we'll recommend airway clearance just with illness in those patients. Initially, in kids who have a little bit more breathing muscle strength, we'll start with just chest PT to help move secretions. It's important to know that if we're doing chest PT, we need to make sure that we're helping to get the secretions out of our patient. If we're doing things to move up secretions but not getting them out of the lungs, we can actually make things worse because we're essentially going to be blocking off bigger parts of the lung. So usually if we're doing chest PT, it would be on a young kid that has a pretty good cough, or if it's a more kid with more weakness, then we would be doing the vest, but always would be doing the cough assist after to make sure that we get the secretions out of the lungs. And sometimes you can, before we have cough assist, you can help the child by just basically pushing up on the diaphragm as they're coughing to give an extra boost to make the cough a little bit stronger. And then once we're at 50% predicted FVC, or if we're having kind of more chronic breathing difficulties with illness, we'll usually recommend using that cough assist machine, which would typically be done twice a day routinely, and then as often as needed when you're sick. So when I'm sick, I'm coughing all the time. So doing them even every hour at home would certainly be reasonable. Sometimes we'll start with every 4 hours, but definitely when we're sick, we're coughing all the time. So it's really is. Good.
Sorry, what is the manual cough assist? What do you?
Sorry, I don't have a video, but essentially what you would do is if you could time it with the coughing, so it's more helpful on older kids. But essentially when they're coughing, you just give a thrust to the abdomen up on the diaphragm, and that helps to make the cough stronger. So you'll just do a little bit of a diaphragmatic thrust that's timed with when they're coughing out. Yeah.
This is to help, because I remember like my kids had asthma and cupping on the back to loosen it. They would always taught us to do that, but this is to cough it.
Correct. So the chest PT, the coughing, that helps to move the mucus.
Yeah.
which then if your lungs are strong enough to bring out the mucus, that's fantastic, then you cough it out on your own. If we move it but we can't cough it out, we can either do a little bit of the thrust, which the respiratory therapist can show you better than I did, or when we have the actual cough assist machine, we can use that to clear out secretions as well. But it's basically a diaphragmatic thrust that you try to time with the coughing out part. And so with older patients, they can usually coordinate, and so you can work together to sort of do the maneuver together if you don't have the machine with you at that time, or if like we haven't ordered it yet but are sort of working through insurance to get it. Thank you for asking the question, and feel free to ask any questions as we go along too. So just a little bit more about the generic name is mechanical insufflation or exsufflation, or the cough assist machine. There are lots of different brands, none of which I have any preference over than the others. So what this machine does is it does two things. So when we call it cough assist, it kind of isn't the best name because it also helps to inflate the lungs. So we use it to get secretions out, but just as importantly, we use it to get air back in the lungs, because if we think of the lungs like a balloon, if we're sucking air out, you'll end up with smaller lungs, but you want to, after you get the mucus out, push air back in to reinflate the lungs. And so what this does is essentially you'll put a mask over the face, and then it pushes air in and then sucks it back. Every time you do an in and out, the mucus actually moves closer to the mouth so that you can get it out. And so typically we'll do 5 in and outs per what we call a set to move the mucus up higher. And then either our kids will spit out what's up there, or if it's hard to get out, then sometimes we'll have suction equipment to get it out. So that would usually be done 3 to 5 sets of 5 to really move out those secretions. And with the cough assist, just like with the manual cough assist sort of pushing up on the diaphragm, it works better if we're able to time the breathing in with when the machine is pushing air in, and then coughing with the machine when it's sucking out. So it's using our patient's strength, but it also is more comfortable, or I guess more correctly, less uncomfortable if we try to time it together. And then we do have the ability to set pressures, so inhale pressures and exhale pressures, and then the amount of time that each are happening to best get secretions out. Some of the machines have an ability to kind of sense like vibrations with the cough, and that can help to move things, and so that can be turned on and off as well. And I think, so just as importantly, especially, so when kids are sick, it's really important to get the secretions out. When they're well, it's helpful to get secretions out, but then at the end, we want to make sure that we reinflate the lungs. So you would do positive only or inhale breaths to reinflate the lungs to keep them better expanded. And so those are the main things I was going to talk about in terms of sort of clearing out secretions, and I'm happy to answer any questions after. And then I was going to talk some about sleep in patients with Duchenne. So in general, when we sleep, anybody, no matter what the diagnosis, there are some changes that happen. So we'll tend to have higher carbon dioxide levels at first, one, because we tend to take smaller breaths, and we don't breathe quite as much right when we start sleeping. And then there's a little bit less of a sensitivity to carbon dioxide levels, so you tend not to have as much of a drive to breathe right when you go to sleep. When we sleep, we also have less tone in our bodies in general, but specifically in the back of our throat and in the larynx, and so that causes a little bit more resistance to moving air in and out of the lungs, and that is normal and expected. And then one part of sleep called REM sleep, rapid eye movement sleep, is distinct from the other parts of sleep because at that time we actually are paralyzed, and the only part of our breathing is really dependent on our diaphragm. So just that dome-shaped muscle is important for REM sleep. And so during REM sleep, we tend to have less rib movement, and so smaller breaths. And then as a result, we also then breathe faster to make up for the smaller breaths. In patients who don't have any underlying issues, these changes really don't cause any significant problems. In Duchenne muscular dystrophy, we see a little bit of an exaggeration of some of these things. So the tone is even lower in the back of the throat, and so when you have a little bit more collapse to the back of the throat, it can be harder to get air in and out, which increases that resistance to airflow and increases the likelihood of sleep apnea. And then also when we're lying down, like when we're standing up, gravity helps to move all the stuff in our abdomen down, and so the diaphragm doesn't have to work as hard. But when you're lying down, the abdomen is sort of pushing up against the diaphragm because we're not able to get the benefit of gravity. And so sometimes, especially in kids who are weaker, it's harder for the diaphragm to push down and move the abdominal stuff out of the way. This causes you to basically to have smaller breaths, and then you're more likely to then hold on to carbon dioxide and also breathe faster, because the only way to get rid of carbon dioxide is to take bigger breaths and or breathe faster. So if you're not taking as big breaths, you have to start to breathe faster to get rid of the carbon dioxide. And then in REM sleep, so like we had mentioned before, the breathing is really diaphragm dependent. And so in REM sleep, then if your diaphragm, which is a little bit weak, is doing most of the work, we tend to have a little bit more difficulty with oxygen levels and carbon dioxide levels. And so when we do sleep studies, we tend to see more problems with everyone, but specifically with Duchenne patients, more difficulties with REM sleep because we have really are only using the diaphragm to help with the breathing. There is some thought that there may be there's definitely decreased REM sleep in patients with Duchenne, and there's some thought that perhaps it's protective, meaning that it's a way that the body protects itself by just having less REM sleep. And I think that's a hypothesis, but not truly clear. And then sometimes when we do sleep studies, we see something called pseudo-central apneas, which is essentially where the diaphragm's weak. It doesn't cause the chest wall to move, so it looks like the patient's not making an effort to breathe, when in fact they are, but the chest wall is just not moving enough because the diaphragm is pretty weak. So that can sometimes be challenging when they're reading sleep studies. So other things that can be more specific to Duchenne is that patients with Duchenne often do have scoliosis. And so scoliosis kind of affects the way that the muscles are able to do their job. So when you're not pulling everything down, but at different angles, that the muscles are not as effective with whatever strength they have. So we can similarly have smaller breaths, retain carbon dioxide, and then have areas that don't open as well, and you can get what we call atelectasis, which is areas that kind of stay deflated and may need a little bit extra help to open up. And then another part to patients with Duchenne that can contribute to sleep apnea is that with time, there is a tendency to be getting a little bit overweight. One of the main reasons is initially, you're walking around doing normal kid stuff, and then you're a little bit less active, but still have the normal appetite. And so you're eating the same amount, but not burning as much calories. You're a little more likely then to gain weight. And then certainly the steroids, which help with inflammation and help to keep the muscles stable, also increases your appetite and can increase weight gain as well. So those are things that can make you more likely to be on the heavier side, which can add on to some of the issues with sleep apnea. So in terms of the signs of sleep apnea, there can be snoring. Patients can be tired, hard to get up in the morning. That can be really challenging in teenagers because they don't sleep very much, and so there can be any number of reasons to be hard to get up in the morning. Sometimes kids will have difficulty breathing at night, which may be a sign of sleep apnea. Waking up with headaches in the morning can be a sign of sort of holding on to carbon dioxide or having headaches throughout the day. Those can also be signs of sleep apnea. Sometimes patients can wake up a lot at night, and sometimes it is just because they feel uncomfortable and need to be turned. I think other times it may be hard to determine whether somebody's waking up because of sleep difficulties, so they're kind of short of breath, their heart's beating a little bit faster, and then you wake up and then notice that you're uncomfortable. So sometimes the awakenings may not just be discomfort, it could also be some element of difficulty breathing, waking you up, and then recognizing that there's some discomfort. Being really sleepy during the day can be a sign of sleep apnea, but it could also be a sign of being a teenager, which, there's lots of stuff to do and not enough time to do it, so kids are often sleepy. Younger kids tend to be more on the hyper side. Older kids tend to be more sleepy. And then sometimes there can be difficulty concentrating. So if you guys are struggling concentrating, it's probably sleep apnea, not me. But sometimes difficulty concentrating just can be because you're so tired, it's hard to pay attention. Histories aren't always reliable because it's hard to keep track of every single thing going on. And then sometimes there can be other reasons that we could say is why these are happening. And so, we may be more likely to say, well, maybe it's not sleep apnea. We do have objective measures that will will cause us to get sleep studies. So we have the subjective ones, like the symptoms you guys are talking about. And then if a patient's not walking, or if the FVC is starting to decline, or we see that CO2s are 45. So we send you to a sleep study, which obviously you get normal sleep when you have all that on your face. And so we generally are still able to get enough information to make some conclusions. I think the more somebody sleeps, the better we can feel comfortable that we're getting good data. But some of the things that we look at are it's called the apnea-hypopnea index, or the AHI. So we see times where there's pauses in breathing or shallow breaths. We get an idea of how much that's happening per hour. And then we'll also see if there are oxygen issues or increased carbon dioxide levels, which may then push us more to being more aggressive with treatment of sleep apnea. And then sometimes if somebody's moving their legs a lot, that can cause poor sleep, and it can be a sign of iron deficiency. So those are some of the things that we'll look at based on the sleep study results. And then what do we do with the results? So in younger kids who have mild sleep apnea, so they tend to still have pretty good muscle strength. If it's mild, we'll try to do medical things like Montelukast or nasal steroids. That helps to sort of open up the nasal passage. And then it decreases some of the irritation in the back of the throat so that breathing is more comfortable. And then in patients with significant symptoms, moderate sleep apnea or severe sleep apnea, we would tend to be then more aggressive. Like any kid with sleep apnea, if the tonsils are big, then we'd refer to ENT to see if those can come out, and then also the adenoids. And then if we see severe sleep apnea, or if the patient doesn't have big tonsils or already had them removed, or if we see that the carbon dioxide levels are high, then we'd start positive airway pressure or non-invasive ventilation at night to help with sleep. And so what is positive airway pressure or non-invasive ventilation? So essentially we'll use a mask that's hopefully over the nose, sometimes can be over the nose and the mouth, to push pressure into the lungs to keep the airways open. So generally in kids with neuromuscular weakness, we would recommend not using CPAP. So CPAP is usually the way that we treat obstructive sleep apnea, which in patients with obstructive sleep apnea, there tends to be an area that's narrow that we give a high enough pressure to open it up, and then you can breathe comfortably once that's open. But in patients with weakness, you would tend to want to give a breath. So you'd give two pressures. So you'd have a set pressure called an EPAP, which keeps the airways open, and then the machine senses when you're trying to breathe. It gives you an extra pressure on top of that to expand the chest wall and give a bigger breath so that the lungs can stay nice and open, and so that you can also breathe off carbon dioxide. And then we would adjust the settings based on a sleep study first, and then based on what we see from the downloads from the machine. We tend to like to set a rate with the BiPAP because we don't want kids to be breathing 18, 20 times a minute at night. We want to make sure that they get nice big breaths. So we would tend to set a rate. I think you all know it can be challenging to get people comfortable with BiPAP and CPAP, and so we'll work with the sleep lab, work with our respiratory therapist to try to get the best fitting mask so that there's less leak. And it can be certainly challenging to do. Ideally, we have a nasal mask or a nasal mask with a chin strap, because when we're pushing air into the lungs, we're also pushing air into the belly, so that there's a chance that you could vomit, and we'd rather you not vomit it in the mask and have the ability to vomit elsewhere. And so the nasal mask would generally be preferred for that reason, but sometimes if somebody's breathing through the mouth, you really don't get anything by pushing air in the nose and then having it come out the mouth. And so in patients who are able to tolerate BiPAP, it does help to lessen those sleep symptoms. And we do see that it helps to stabilize some of that lung function and decreases the rate of decline. And then I think I mentioned why we'd want to do the two pressures. So we give the pressure when you're breathing in to expand the chest, give a bigger breath to keep the lungs more open, and then also to help get rid of carbon dioxide. We'll skip that one. So just kind of to summarize what I had talked about, so the lungs do three main things. They get oxygen into the body, they get rid of carbon dioxide, and then they help to clear out secretions. We use history, physical, and PFTs to help to assess the lungs. The most important values are the FVC, the forced vital capacity, and then the tests of muscle strength, the maximal inspiratory pressure, the maximal expiratory pressure, and then the measures of cough flow. And then we'll use the cough assist machine if patients are having weak breathing muscles or prolonged illnesses. And then it's important to remember that the cough assist helps to clear secretions out, but also helps to reinflate the lungs. And then we'll get sleep studies based on symptoms or based on PFTs. And then typically the sleep apnea is managed with medicine, surgery, or positive pressure or non-invasive ventilation. And we tend to want to have two levels if you need the mask or BiPAP, because it helps to get rid of carbon dioxide and keep the lungs better inflated. And I think that was everything. Thank you. If you have any questions.
Cartoons make the best presentation. Good job.
Did you,
How often, he's 17, has never had any issues so far of any sleep apnea, but the doctor still orders a sleep study like every 1 to 2 years?
so at his age, that would be typical. So usually I'll get my first one with symptoms or around like 10 to 12 years of age. And that sort of guides when to repeat the next one. And so if at 17, if he's had basically normal sleep studies, then I think you want to be a little bit more aggressive. And so that 1 to 2 year range, I think makes sense. If you're noticing any changes during the day, like he seems like he's more tired or having more difficulty concentrating, you may want to check it sooner. But I think every 1 to 2 years is definitely good. I might err more on the every year just because we want to try to help as soon as we see that there are changes.
I see people connecting, and you just don't want to cut that off. But I am going to go ahead and let me see. Okay. Let me pull up and introduce. Oh. I am going to introduce Nicole Hanlon. She is the head of the Hummingbird program at Penn State Health. So she is going to talk about palliative care today, which I think is a really critical topic because I think that there's a lot of misunderstanding around palliative care, and palliative care is also extremely important, not just for older individuals, but for younger individuals as well. So with that, I will hand it off. All right. And it's just the arrows.
Know how to project. Break the tech before I even start.
Always, you have to have something.
Thank you. So I'll warn you that I brought myself some notes because I'm pretty passionate about the topic, and so I don't want to commandeer the rest of your afternoon. So I'm going to try to stick to the notes. So my name is Nicole Hanlon. I am the nurse coordinator of the Hummingbird program, which is the pediatric palliative care team at Penn State Health Children's Hospital. So I really appreciate your willingness to take the time to allow me to come and talk about this topic. I thought I would just sort of lead off by acknowledging the elephant in the room. How many of you were like, yeah, let's talk about palliative care? Was anybody like really excited about the notion today? Was there, I don't know if anybody feels brave to say, was there any kind of fear and trepidation, a little of like, maybe we'll take a break during that talk, not sure I'm really up for that conversation. I recognize the weight of this topic. And I really appreciate the brave souls that say it's hard and it's important to talk about. So I really do appreciate the opportunity that you allow me to do that. And really, as much as you guys are interested, I would love to hear thoughts, questions. I would love to hear fears and anxiety about what palliative care is. So please feel free to ask questions along the way. Again, if there's things that worry you, or, I'd be happy to sort of talk about how we think about any of those things. So I figured I would just start off with a bit of a definition. So palliative care is specialized medical care for people living with serious illness. This care is focused on providing relief from symptoms and stress of the illness. And the goal is really to improve quality of life for both the patient and the family. So palliative care really can be for any child or young adult or adult patient that has any kind of serious illness. Duchenne's is certainly a diagnosis that we will see young adults, but really the number of children and young adults we see really spans the spectrum of different disease trajectories, disease processes. I do like to point out that palliative care is a medical specialty. So just like pulmonology, just like neurology, the providers on our team did fellowship training. The members of our team have training in this area of expertise, so this really is a medical specialty. I think it is a relatively young medical specialty, but sometimes people sort of misinterpret and say, oh, that's just the team of nice people that kind of come and have warm and fuzzy conversations sometimes. But just to say, folks are trained, and there usually is a method to our madness when we're meeting patients and families along the way. So when I meet families for the first time, I am often the person that is sort of coming into the room and introducing our program. And so I just figured I would act like I'm coming to introduce our team to you guys. So what I typically say is we are a group of folks that come alongside kids and families and young adults who are dealing with complex medical illness. We can do a number of different things depending on what families find most helpful. So for some families, they would like to have a resource to help them understand complicated medical information. What we hear from families all the time is that it's really important to have all of your specialty medical providers, but oftentimes the more specialists that are involved, sometimes the big picture gets lost. So everybody's looking at their little piece of the puzzle, and sometimes you need the people to kind of step back and look at the big picture and see how it all goes together. And sometimes that's how I describe our team. So we can help process all of that complicated medical information. We can also help folks know who to direct their questions and concerns to. So again, when you've got 5 or 6 medical teams following, sometimes it becomes confusing to know who's the right person to ask this question to. And so sometimes families find it helpful to sort of have us help point them in a right direction. For other families, sometimes it's really important to have a group of folks that can sit down and hear how they think about medical care, think about how you make decisions, think about the things that are important to you as an individual and as a family, and to translate that back to all of the good medical teams caring for you to say, we got to make sure the medical plans that we're putting in place actually take those unique factors into account. So if something's really important to you as a family, we want to make sure we are aware of that and thinking about it as we are creating medical plans. Certainly some other things that we can do for families is to help with complicated pain and symptoms. So these are usually things that your Your typical medical team is struggling to get a good handle on, and sometimes they are reaching out to us saying we could use some extra help. And so that could be something that we can help with. And then lastly, actually 2 other things broadly that we can help with. Planning for the future. So sometimes it's really hard to predict which way the road is going to twist and turn. And we have what we kind of refer to on our team as the knowing, right? We've sort of walked this journey with many families before. And so we can sometimes anticipate things, and at least enough to say, here's something that you should think about, because it could come up in the future. So this could be related to medical decision-making. This could be related to as you're transitioning to adult medical care from pediatrics. And so just helping you know what things are important to think about, and then again, sort of allowing you to personalize those things for what makes sense for you guys individually. And then lastly, one of the things that we can offer is emotional support. So I always say we recognize that the twists and turns of the journey are frustrating sometimes, are stressful, can be a little bit scary. And so we can just sort of go along with you on the way, and sort of try to be attending to your emotional needs. I'm going to just stand here and hold the cable in place, maybe. You guys really didn't want to hear this talk, did you? Some other important things to be aware of when it comes to palliative care. So we are an interdisciplinary team. So we really, the team I work on is made up of a physician, a nurse practitioner, myself as the nurse coordinator, and we have a clinical counselor. When you look at other institutions, they often have chaplains, social workers, art therapists, music therapists, child life specialists, on their palliative care teams. And that is, again, because part of our mission is really to try to provide as holistic support as we can to patients and families. I always like to point out that the care we provide is offered in partnership with your medical team. So I like to say we never take over care from the trusted team that's already invested in a patient or a child. But we come alongside as an extra layer of support. So palliative care really is appropriate at any stage in a serious illness. I would say that the majority of the patients that we are caring for are seeking curative interventions, are seeking life prolongation, are interested in exploring experimental treatments and clinical trials. And so this care that we provide can happen alongside all of those interventions. So there is no limitations to your care if you are involved with a palliative care team. The other thing I'd like to point out is that our care really can be provided over time and can change as an individual's needs change. So certainly priorities change over time. Priorities may change as new things are coming up in your medical journey. And so we're always kind of looking at and reevaluating and trying to make sure we're understanding what feels most important to a person at any given time, so that we can tailor our support appropriately. So I want to talk just a bit about prognostication. Are you guys familiar with that term? No? Okay. So prognostication is really kind of what a lot of folks do in the medical world, where we're sort of trying to predict the future a little bit, where we're thinking about things like how long do we think somebody with a particular diagnosis would have to live? What do we think their disease trajectory is likely to look like over time? And what are the things that we can try to do to help support that along the way? Have any of you in your kind of medical journey heard a provider say, "I wish I had a crystal ball"? I think that's something we say a lot. Or have any of you felt frustrated when the medical team sort of goes, "Well, we don't really know, and we can't provide you with the concreteness that you really wish"? It's amazing sometimes we can know so much in medicine and at the same time know so little. And it can be really frustrating when we can't sort of tell you what the future holds specifically. So that kind of, in a nutshell, is prognostication. It's us trying to think about that and do the best we can for our patients and families based on what we think a disease process may look like. So I will tell you, prognostication in pediatrics is incredibly difficult. I'm going to mention a couple of the things that make it challenging, but this is not a comprehensive list. First and foremost is kids and young adults are some of the most resilient human beings I have ever met in my life. So this is wonderful, right? It means our kids can be sicker for longer and then recover and get better. And just bounce back from some really incredibly complicated medical problems. And so this resiliency of young adulthood and childhood makes it incredibly hard to predict what the future may hold. And so there's been lots of times, I will admit, when I have really worried about a patient. Somebody's in the hospital and they're really, really sick, and I think, I'm not sure that they're going to survive this illness. And then it's like they hear me and go, "You just wait and see what I can do." And so we always try to hold very loosely our certainty when it comes to what children are capable of and what they may or may not be able to overcome. Another challenge of prognostication is variability in diagnoses. So I think in the palliative care team, we sometimes are seeing the most complex of any illness. But you see, to say, "Oh, I'm seeing a patient with muscular dystrophy," does not mean that I'm going to know how that disease affects them individually and what problems they have had, how that disease has presented for that individual. I have also seen, I'm thinking of a family that we care for their children. They have Duchenne's, but they also have an endocrine disorder in addition to. And so that endocrine disorder complicates their life and impacts their muscular dystrophy disease. And so when you have multiple diagnoses, that affects what their disease course is going to look like over time. So that makes it challenging for us to predict what the future is going to hold. Certainly another thing is ever-changing, new and evolving technologies, right? These have opened up the door for really wonderful opportunities for kids and young adults to live longer, to be healthier. But sometimes we don't know what that looks like in the future because it's just too new for us to know with certainty what the future will hold. While all of these make prognostication challenging, they're all good things, right? And so oftentimes in pediatrics, we say palliative care referrals earlier is okay because it gives us an opportunity to get to know the individual and the family and to begin to look at trends and to see what may be happening over time. So another incredibly important aspect of prognostication is, we kind of refer to it as adding sand to the hourglass. So in all my years as a palliative care nurse, I have never met a family that has said, "Okay, I've had enough time." So it's okay if we are encountering end of life, not a big deal. So even when we are navigating end of life with a patient, we are still looking for opportunities to add time. So it may be at one point we're talking about adding years, and it may be at another time we're talking about adding hours or days. But we're always trying to look to hold both. So it's an interesting thing to navigate, but a really important aspect of the care that we provide. So I just told you all the reasons why this is hard and complicated. So how do you decide when is the right time to involve the palliative care team? That is a question that we get a whole lot, like when is the right time? How do I propose this to families? And I just thought I would point out a couple of perhaps times in your journey where you might say, is now the right time? Recognizing that time is probably different for each and every individual along the way. So one of the things that perhaps is a good time is when there's evolving health concerns, when something is changing over time. So this might be something like changing respiratory needs, starting to need new technology. This could be maybe change in heart function or functional mobility, or even when symptoms are becoming a little more impactful in a way that people are starting to say, my life doesn't quite feel as good as it used to be, and I'm wondering if there's some things we can fine-tune to try to make it better. Another, another time may be just points in time where difficult medical decision-making is coming up. So I think of Dr. Sankorakal referenced scoliosis. So oftentimes we might meet a family as they're contemplating spinal repair and want to talk about the pros and cons of a big surgery. This might be weighing options around enrolling in a clinical trial or considering an experimental treatment of some kind. And so just sometimes folks appreciate having a bit of a sounding board to just think through medical decisions and help them kind of weigh the pros and cons for themselves individually. Certainly, we can be helpful at a time when pain is becoming more poorly controlled or symptoms are becoming more cumbersome. And then lastly, anticipating transition to adult health care. So this is really important because there's a lot of things that change at the magic age of 18. And so suddenly, parents may not be able to make decisions for their young adult the way they did 6 months ago before they had a birthday. And so it may be a good opportunity just to talk about what things do we know of that change at 18. Some of that is legal. Some of that is navigating the new medical system. We were just kind of chatting about that. And even thinking about some hard things, like what happens if, as an adult, you aren't for some reason able to make decisions for yourself? Who would you want to make decisions on your behalf until you are able to kind of be in a state of health to make decisions? And so just sort of starting some of those conversations and even planting seeds about things to think about can be really helpful. Sometimes, I would say in the ideal sense, but this timing is a little different for everybody, sometimes it's helpful to start those conversations early before somebody turns 18, because sometimes it's just nice to get the information and to be able to think about it for some amount of time before you're sort of forced to jump into the deep end of the adult health care pool. So any questions about any of that so far?
I love the idea of the transition of care piece, and I'm wondering, do you need a referral to get to palliative care, and like what does that look like?
Yeah.
Because that's a great answer
Yes.
to that problem.
That is a great question. And I would say that is a good question to go back to your home kind of medical community and say, how do I get a palliative care referral? So for our team, we do need a physician referral. And I will acknowledge, I think Dr. Sankorakal usually has his eye on it, and he's usually the person who is making the referrals as adolescents, as boys are getting a little bit older. So I appreciate he's got his eye on it, because I think it gets missed a lot. And I always, we once had a family who we were meeting with, and the mom said, people keep telling me, all these medical people want to be helpful, and they keep saying, tell me what you need and I'll be glad to help. And she's like, I feel like people keep handing me keys to a spaceship and telling me to fly to the moon, and I don't know how to do that. So, I think sometimes it's helpful just to have people to help you think about the things you don't know that you don't know, right? So we're always happy to do that. I think some teams are self-referral, so some teams need a medical referral, so it really is kind of reaching out to whatever local palliative care resource you have. There are some communities have community-based palliative care programs, so it is getting familiar with the resources kind of in your local area. Thank you for asking. So I do want to acknowledge the hard part of the work that we do. I do want to at least speak a little bit about end-of-life care, because this certainly is part of the work that our team does. I like this graphic because it sort of hopefully demonstrates that palliative care and hospice care are interrelated in some way, but they are separate. So the way I describe it, and I don't know if this is helpful or more confusing, is to say all hospice care is palliative care, but not all palliative care is hospice care. Palliative care, and I think the key distinction between the two is kind of the All right, guys, would you like me to just wrap it up?
Like, no.
So I think the key kind of distinction between the two is kind of the when. As I mentioned earlier, palliative care is really appropriate at any time. You can seek palliative care in addition to curative interventions, and really we can stay with you for as long as it is helpful. So for many of our patients and families, we know them for years, which is really wonderful because you are having an opportunity to really build trust and build a relationship. Hospice care, on the other hand, really falls into the context of saying we think somebody has 6 months or less life expectancy. This is really hard to predict, again, for all of the kind of prognostication stuff I talked about earlier. But when somebody from the medical team sort of says, I worry that we're in that time frame, hospice can be a really helpful resource because they can sort of provide all of those tenets of palliative care: pain and symptom management, family support, spiritual care, really in the context of that last stage of life. Hospice care can happen in a home. Hospice care can happen in a hospital. So it really is an opportunity to really focus on making that time as good as it can be for as long as it can be. You'll see in this graph, I was trying to think of a picture way to demonstrate this. There's kind of a fuzzy line on that yellow circle. There is something that is part of the Affordable Care Act, which passed in 2010. So this is federal law called the Concurrent Care for Children requirement. And basically, this is kind of the legalese. This is what the law actually says. But basically what this says is if a child receives federally funded Medicaid, they can receive hospice care in addition to continuing any curative interventions that they find helpful or that the medical team finds helpful. And this really revolutionized how we do end-of-life care. Basically, what this means is we no longer have to pick and choose. So if we worry that we're in that 6-month window, we can refer to hospice and we can begin to build the relationship with the hospice team, and we can continue curative interventions, we can continue anything that is really helping to improve quality of life, and we don't have to decide between the two. What this means for us is we have been able to refer much earlier when we have made hospice referrals. I'll clarify a little bit. So in a traditional hospice model, and this is the way it works in adult medicine, is when somebody is referred to hospice, all curative interventions and life-prolonging interventions end. So a lot of times people would get referred to hospice, and a lot of the medications they're taking, they have to stop taking if they're receiving therapies and different things that really are helping their quality of life. Some of those things have to stop. So it feels really abrupt. And again, it's such a harsh transition to end-of-life care. And this really allows us to do that a little more gently. And frankly, we have lots of conversations with families along the way where we will say, I worry that we're in that window. And families will say, I worry, but I really hope you're wrong. And we say, well, we hope we're wrong as well, but are you open for the hospice referral? So, sometimes we can do a little bit of both and. There's only one slide left, so you won't have to run back too often. It really just gives us an opportunity. The way I look at it is it allows us to really pick all of the best resources all together. I want to be able to end on an inspiring. I wanted to add this quote in here. I do really appreciate standing in front of this room and being able to sort of talk about the hard things. And one of the things I've learned, so I've been doing this work for 20 years, and one of the things that I've learned is that hope never ends. Hope changes over time, but even through end of life, hope never ends. And so I really like this quote, which says, hope served as a bit of a survival mechanism for me in the darkest places of worry, sadness, and fear. There was a tiniest bit of light I would call hope, and I can still remember how that feels in my heart. It is such a gift. So. Thank you, guys. Got to provide questions, or we can see what other mayhem ensues if I just stand here for any longer.
Anybody have any questions?
So when we are in that transition at Penn State Hershey, are you our team at Penn State Children's and then goes to adult? Are we seeing the same palliative team from children's to adult?
So the way the pediatric palliative care team works is we will follow you as long as there are pediatric providers following. So we kind of help you through the transition. There is an adult palliative care team. They unfortunately don't follow over length of time as well as our team does. So I think we do our best to try to help plug you into the right resources, recognizing that they're different than what they are in pediatrics.
Well, and I would ask that maybe your team open their discussion to an easier system because our boys are living longer. Right? So 18 to 21 is not,
Right, falls short, right?
Right.
Yeah.
So it's not realistic anymore, thank goodness.
Yeah.
Those talks, I'm hoping would happen, that we could,
Yeah.
the adult system kind of meshed a little.
Yeah. I think and I don't know, I'm gonna put Dr. Sankoff on this. Do you have an age in what you transition, or do you follow? I know you guys tend to follow through young adulthood.
Yeah, so we don't have a set age. It's usually around 21,
Okay,
21 to 22.
okay.
That's what it is.
Yeah, so I agree with you. I was, it's funny, we sort of have a handful of young adult patients who are getting ready to transition and are really starting to build the energy around, we need a better transition plan. And I keep encouraging those families, I agree with you, and we need the family voice to sort of help this rise to the level of importance with kind of hospital leadership, for people to really appreciate the importance of that transition. So I'll get on that train with you.
I think that's just in general, right?
Yeah,
Not just palliative care.
yeah,
I
yeah,
think it's
wholly.
care
Yep,
across the board, and I think that, but she has a really good point, especially for, and I think this is it being in the past a pediatric disease, and providers still see some, in some cases, through, right?
Mhm.
And so there's a comfort level, especially as a pediatric, like you start in pediatric and there's a comfort level that comes with that. But adult providers also need to be, I think, ingrained, like she said, coming in earlier than 18
Mhm.
to start having the conversation and to help with that transition. I don't know if it's 16 or, I mean, you're starting the transition at 12, right? Like that's the starting to advocate for yourself and those checklist pieces. So how do we bring in the adult providers 12, 14, 16, whatever that may be, so that it's more of a, and again, not just here, across the board.
Yeah, yeah,
How do we, because as an adult provider, right, because it was primarily a pediatric disease, they aren't comfortable treating it at the adult stages,
right.
but they need to be. So how do we, I don't know, it's just my little rant for a moment. Good one. Thank you.
Yeah.
It's a problem, and the only way to fix it is if providers are having a discussion, because we can talk to providers and have those discussions, but without pediatric and adult providers coming together to try to provide a solution, we get nowhere.
I think I am part of a pediatric palliative care coalition for the state of Pennsylvania, and we've been recently talking about this topic kind of broadly, right? Recognizing this impacts lots of different disease diagnoses. And so I'm hoping maybe January, February that we're going to do a bit of a parent seminar, just a 1 hour.
Yeah.
So maybe that's a starting place, you know, because I really do think, you know, it's how do we get that conversation started in our areas, and how do we sort of help each other, and really, you know, I work in pediatric medicine, so I'm not familiar with how the adult hospital functions and sort of navigating some of those things. So even for some of our families, when they're looking to me for some certainty, it's frustrating when I can't provide it for them, and I can plug them into some resources, but it's, you know, it's hard when you build a relationship and you have the trust to suddenly say you have to build anew.
Well,
with,
for 18 years you've had this
Right.
relationship, right? So
Right.
it's,
yeah.
Any questions, comments?
I have a comment. So I have a couple patients that have gone through the transition to adult care. And what I'm hearing is these adult neurologists are not nearly as schooled or educated as the pediatric neurologists with this disease, with Duchenne. And so we are, you know, they're struggling a little bit with that. So I really think that as well as there needs to be a protocol written for each hospital on how to transition, and starting earlier, not waiting to 18. But I also think that we've got to get more education about this disease state and treatment options to our adult neurologists.
Well, cardiologists, neurologists, pulmonologists, palliative care teams, all of it, right?
Yeah.
Absolutely.
I think this is a little bit, this is an oversimplification,
Yeah.
but this is a little bit of the, you know, the challenge of prognostication, the new and evolving technologies. And this is where, you know, that's a wonderful thing, and yet now we're sort of creating a new problem which is a great problem, right? Of needing the education and needing the systems built. And so we see that in a lot of pediatric medicine with a lot of diseases that were once sort of considered to be, that these are childhood diseases and the individual will die in childhood. We see it in many diseases that, it's wonderful that kids are living longer, but now kind of medicine and our systems have to catch up. So I would love anybody. I will champion, or I will help anybody that wants to champion that cause. I wish I had the answer to that.
Sorry, you got the brunt of that one.
No, it's an important.
Palliative issue for sure.
Yeah.
I do have one more question, and it's, so I know people look at palliative care as kind of like pre-hospice, right?
Mhm.
Is there any effort in the palliative care space to rebrand that? Like, because I see that I've worked in hospice for like a hot minute, and it's so different, and yes, you have to have a serious disease, but you don't have to have 6 months to live.
Correct.
And you have resources, and
Correct.
you can keep, you know what I mean?
Yeah.
Is there any effort?
So I will speak to our experience a little bit. So you'll notice that I said I work with the Hummingbird program, right? So our program started at Penn State in 2007. So actually pretty progressive, actually, that we started a pediatric palliative care team that early, because it really is a young field. But boy, the intense conversations around what we will call it, because we could not call it palliative
Yeah,
care.
people are afraid of
Right.
palliative care, and there needs to be education. about
Right,
that
right.
thing.
And
It's
what
not
I learned, because I was sort of the passionate proponent of we need to call it what it is and we need to educate people, and obviously I lost that conversation. but I have learned it's really easy to walk into a room and say, hi, I'm with the Hummingbird program, and that doesn't mean anything to anybody, right? And so it gives me a foot in the door to say, let me tell you about what it is I do. And what I have found, and we use the word palliative, so we don't sort of pretend we're not the palliative care team. But what I have found is the most vocal advocates for calling it palliative care are the families themselves. So after they get to know us, and after we prove that we have some worth and value, then families will say, have you met the palliative care team? They're great. And so it really, it feels like it's a one person at a time conversation, because there's no way to sort of separate that the end of life piece is a part of our work. It wouldn't be fair, right? It wouldn't be fair to
Put it in that
to
one
it.
category.
Yeah.
And I think
So-
that's, Marie, to your point, I think conversations like this and her being here and sharing and educating is a big piece. It'll be on YouTube later for not just the people here to watch, but others to watch as well. We had our webinar on palliative care. So trying to not only educate here, but educate the community. And as we're having conversations with families, like at PPMD, at Cure Duchenne conferences, like they've had breakouts on the same, because it's about creating that knowledge that palliative care is not just an
I'm glad you lost.
I will also say, I tell providers this a lot, and I don't know if I've ever lectured you guys on this. I sometimes say, because I think sometimes providers really feel an obligation to their families to explain why you're bringing in the palliative care team, and sort of wanting to make people feel okay about meeting us. And I tell families, or I tell providers a lot, it is okay that people are not happy about meeting our team, and it is okay that people are anxious. I've walked into some very angry rooms, and that is okay. I know nobody's angry at me yet. I haven't done anything yet, they're angry that they are living in a world where they need to meet a palliative care team. And so it is sort of up to us to begin to build the relationship and to show that there's something redeeming and hopeful that we can do. And I think I can't think of very many families where we weren't, over some amount of time, able to build some trust and rapport. So like, I am okay going into a room where people are a little anxious or a little, even a little angry that's okay. You aren't obligated to trust me until I prove that there's something trustworthy in what I'm offering. So, well, thank you for the time. I feel like I got on my soapbox a little.
All right, so I am going to go ahead and call up Kelly first. So Kelly is going to do a short presentation, but she's also going to share her experience as well. Well, yeah, no, she's just gonna chat with everybody.
I think you know what Duchenne is. I wanted to tell you that. So the reason I was sitting over here and I thought, oh, I have something functional I can actually, at least share with people. But I'll kind of share our background, I guess. So my son Gavin. Oh, I hate microphones. Okay, so my son Gavin is 9. He was going to come with me, but he bailed on me because he's 9 and I'm not cool enough. So he was diagnosed in 2019, right after his 4-year well exam. We noticed some of the typical things with Duchenne as he was kind of progressing through development. But he was really good at meeting every milestone, like at the very, very end. So then it was like, oh no, he's fine, don't overthink it. So, and then we went to his pediatrician for his 4-year well exam. He had these bouts of his calves cramping, and then it'd go away, then it'd cramp again, then it'd go away. And that kind of led her to call after his appointment, and she was entering notes and noticed the correlation of the enlarged calves and the pseudohypertrophy. So she then sent us to neurology, who did the CK level, and that was like 22,000, which I now know that's really high. And then we did a genetic test after that. So it was like June of 2019 that he was diagnosed. We initially started going to Nemours Children's Hospital in Delaware, but then our most favorite neurologist retired. So now we go to Penn State Health and we love them just as much. So Gavin's doing really well, and I kind of want him to come and show you he's doing great. And, he loves playing with all the other kids. But I think the biggest thing for kind of, I want to say our family, but maybe it's a little bit more me. Hence, my husband's also not here because they like to just go do their own thing. But the thing that I found kind of challenging, because he's actually doing really well from a mobility standpoint, is school. Because we're definitely still in a phase where people are like, oh, I wouldn't have even known. I'm like, well, of course you wouldn't, because he's not doing anything that you can compare that's not quite the same developmentally and strength-wise. So one thing that I started doing with his school, with his permission, because he started kindergarten in the pandemic, so parents weren't allowed to go into the school. I couldn't have any conversations with any of the other kids. I had to rely on teachers who knew nothing about it other than what I told them to kind of help people understand Gavin. And that was obviously really hard being kindergarten. He's our only child, and he had Duchenne, and we're in the middle of the pandemic, and at that point he had never had COVID, so I had no idea how he was going to be impacted either. So what we started doing in first grade, when I was able to actually physically go into the school, is going into his classroom, and at that grade level, I read a book. It's the Dan and DMD book. So I would read a book to the kids and at least get them to kind of think about stuff being different for him, so that it was less about the, I'm worried about, him playing with other kids, and more about he didn't feel like he had to explain it to everyone. So I've done that for, he's in 4th grade now. So I've done that for the last 3 years. I did notice in 2nd grade they were done with the book. I was like, I'm sorry, this is not engaging enough. So I started sharing a video. But what I've noticed every single year, and of course as the kids get older and kind of able to kind of ask more questions and understand more of what I'm talking about, is that every single year there is at least one child that has some medical thing that they make sure to tell me when I'm in there having that conversation. Now, we're in a very small area. I'm about an hour and a half from here, so it's definitely rural central Pennsylvania. So I don't think there's a single child in a wheelchair in his intermediate school. There was one child in his elementary school, and I don't think there are any students that I'm aware of in the middle or the high school that use wheelchairs, or at least not regularly. So from that perspective, I think that's been really beneficial for him. He's very outgoing, but he likes to kind of be prompted and guided to get to that point. So me going into his classroom, every year I ask and I make sure, and I'm like, are you sure? Because I don't want him to get mad at me later after he already said yes. But every year he's able to tell me things he wants me to tell them. So last year in 3rd grade, he wanted me to tell his friends about his infusions because he's on exon skipping therapy. This year he wanted me to do stuff with his friends. So this year I got an idea from another Duchenne mom that I'm friends with, and her husband goes into her son's class and he brings a weighted medicine ball. So I brought literally a playground ball and a weighted medicine ball, and I make them throw it, giving the kind of idea that this is throwing a regular ball, this is throwing a weighted ball. That's probably how it feels for him a lot of times. I think that's done a lot for his self-esteem with Duchenne. One of the things I was mentioning as we were talking at the table is that he's got some stunted growth. He's been on steroids for a while, but this is the first year he's even noticed that he's shorter than the other kids. I'm like, okay. So it's not bothering him. So he'll talk about it. He'll say things to other kids. Well, this year was kind of the most entertaining. Every child told me about their medical stuff in 4th grade, and they talked about it a lot. The teacher was like, okay, guys, everyone's like, I have ADHD, and I have ADHD, and I have ADHD, and I take this medicine and this medicine. I'm like, oh, do your parents want you to tell me all of it? So there's just this level of camaraderie that I think happens, and from our perspective, it's given him the ability to know that if he doesn't want to talk about it, but he wants them to know, I'm willing to do that for him. But he's also willing to talk about it now on his own a little bit. And sometimes he does these funny things where he'll be like, Mom, so someday I might need a wheelchair, and that's okay. And then the one day he's like, well, I have to get infusions forever. I'm like, I don't know, buddy, maybe not. But then the next time I'm like, what'd you say you were thankful for at school? He goes, Duchenne. I was like, okay, I'll go with it. So, of course, he knows that side of the things where I'm like, we would love it to be different. But any way that he can feel okay with it, I think is kind of a win. And I know it won't always be that way because, he's 9, he's almost a teenager, or so he thinks. So, we see those things changing, but I think from that perspective, that's something that I've always felt pretty adamant about. Can't say that Dad has always felt the same, but I'm like, I'll just do it all. It'll be fine. I'm adamant about talking about it because I just think it's a whole lot easier, and I'm pretty transparent and direct. So it's easy for me to do that. And I think Gavin's not naturally that way, but it's helped him a little bit kind of be a little more comfortable about it. So I was going to flip through the slides on this presentation that I did. So this is not the one I do for his classmates, but I now make all of his teachers come in a different day and watch one with me. Because it's one of those scenarios where you can have a billion IEP meetings, but I'm sorry, they're not all reading every SDI. It's just not happening. And I understand why. So my kind of scenario is offering around Duchenne Day, offering hey, can you get at least his team teachers together so I can kind of do this. And they seem to be willing. Sometimes there are teachers that I think should be there that aren't there, but that's okay. We still do what we can. So I basically did this for the teachers, and I also work at Bucknell University, so there's a faculty member that teaches education classes, and I can't remember the name of her course, but it was something about special education, so she has parents come in to talk about different things, so I do this for them too. And sometimes it's at 8 a.m. and they're college students, and they're definitely not listening, but that's all right. So I just kind of go through what Duchenne Day is. I try to both be awareness, but also sometimes I give them the not good stuff too, because I want it to really be real for him, even though Gavin's doing really well. And I know some of these things are really far off. I feel like it matters to kind of bring their attention to it. So these are all the stats that you all know. This video, I forget, there's a whole documentary, and it was made by one of the groups that does they do some treks to. Yeah, it wasn't actually Hope for Gus, but it was like someone affiliated with one of those things. So I have it somewhere. So if anyone wants it, I will send it to you. So I just pulled a clip from this video where it's kind of the video explaining Duchenne in like a simplistic adult way that I thought was a lot better than showing some of the other videos that I use for the kids. So the brain pop video, that I still use for Gavin's age bracket. I think that's probably good through like early middle school, and then they're too cool for it. So I do our little story and just kind of explaining what I already said about how he got diagnosed. And I don't care how old he is, that picture on the slide will never get taken out because it's like my favorite picture of him. But you'll see all the boys in these pictures that he's hanging out with. These are like his BFFs. So we plan to go to conferences together so that they can hang out and we can use it as kind of a mini vacation because there's always someone else to watch your kid. This is where I kind of go through like the stuff that I would say I don't always think about, because we try to be optimistic and recognize all the treatment options that are available that weren't available before, and we're very grateful for how well Gavin is doing. But I want people to recognize all of the extra stuff that's going on outside of school, so that when they don't see a behavior or something happening, and I fill out the little survey and I'm like, no, he really is not focused right now, they recognize some of the other things. And then some of them sometimes I think it just needs to be like smack in front of their face to recognize that this is an ongoing thing, and it's not like he's doing well in his ELA classes now, so everything's fine kind of scenario. And this is actually very outdated now, because now there are more meds. I certainly go through like the general kind of educational challenges that are sometimes mentioned with kids with Duchenne, and they don't all have them, but I feel like there are also things that, he's been evaluated a bunch of times. No one's going to be like, oh, you have this learning disability and this learning disability, because he doesn't really. He just has bits and pieces of things that make some things challenging. And then all of the wonderful organizations. That's the other big thing. I mean, obviously I showed you the pictures of, him and friends. I'm one of those people that when anything happens, and honestly it can be anyone that I know that has some medical something, I will be looking it up and I will be reading it all, because I'm just weird like that. So when Gavin was diagnosed, I was able to find, I would literally say, all the information that I need between probably these 3 organizations. So I think that's kind of a big takeaway for me that I don't think exists in all rare disease. So I think we're really fortunate for that. And one of the, when we were talking about palliative care, something kind of popped in my head, because I put things in here that aren't super positive because I want the people working with Gavin to really know what things are different for him. But generally, we're a pretty optimistic family, I would say, and we're, try to pay attention to the good stuff that's happening. And I complain about a lot of the same things that every other parent complains about with their 9-year-olds, so that's a positive thing. But even when Nicole was talking about palliative care, I think kind of that take-home moment for me is knowing a coworker a former acquaintance coworker who I used to work with, who has a child who just recently passed away, and he's a year older than Gavin. He does not have Duchenne. So, I think the glass half full can't always be half full, but I think it's a lot easier when it's at least almost half full. So I think the positive side is really helpful, and these organizations absolutely give you the tools to be able to have that outlook, but not lose sight of all the stuff that is really hard. So that's all I got.
All right, I'm going to give him a minute to
Hello, I'm Kristen. We are so new to the Duchenne world. My husband James is here, and then our son Killian. He just turned 4, October 16th. He was diagnosed February 28th of this year. To go back to when we started seeing signs with Killian, he was about 2. He was progressing normally, sitting, he was crawling, he was walking. But my sister-in-law said something a little while ago, and she was like, do you remember when Killian just did not like to lay in his belly? And I was like, oh my gosh, I totally forgot about that. So it made me think like maybe there were signs. So before 2, he really did not like to be on his stomach. Makes sense. About 2, he started to have he had a regression in speech. He was saying moo, he was saying cat, he was saying mom and dad, and then all of a sudden it just stopped. And we assumed it was because I was pregnant with twin boys, and I just was like, okay, this world is just crazy right now. It was COVID, you know what I mean? Like, we're just coming out of this, and then we have twins coming into this world, and like our focus is kind of shifted, and maybe that's the regression. It just stopped. Like, his speech just stopped at 2. And then we noticed that he walked. He swayed when he walked, and his belly went out, and he would get really tired. And then at one point, my mom was just like, I don't know, Chrissy, I really think you got to bring it up to the pediatrician. Maybe it's some sort of muscular dystrophy. He had very enlarged calves. He has 6-pack. It's like still to this day, when he wakes up in the morning, he has a 6-pack. And that was just like kind of strange, because it reminded me of like the little Hercules, like the little boy, like little Hercules. And then we went to the pediatrician January 6th, and I won't ever forget because it was my birthday. And the pediatrician came in, and I just said, we're worried about the speech, worried about his swaying of the back, the belly, the pot belly. He falls, and then, she evaluated, and then you could just see in her face like the worry when she had him walk down the hall and get up from a sitting position. Like, you could just tell in her face she knew what it was. So we went, she did blood work, the CK came back, and it was like 12,000. She was extremely worried. She's like, you may have to take him to the emergency room right now. And we didn't have to. I mean, of course, even 12,000 isn't even that bad. But then, like, February 28th, we were formally diagnosed at CHOP. And I feel like I've been doing really well with dealing with the emotions and just understanding what we're going through. But I, thought about this last night, and I'm like, I totally blocked this out, but that moment of when your world just crashes, it just stops, and you're just standing there, and you're like, oh my gosh, what am I gonna do? But then everything else is still revolving. Work is still work. School is still school. Everything is still functioning except for you. So I remember that moment of just, I don't know how I'm gonna function. Like, what am I gonna do? And then it was like this bubble. This Duchenne bubble just swallowed us up and took us in, and it wasn't bad. It was kind of, it was comforting. CHOP had recommended that we reach out, do our homework, reach out to organizations, and the Jett Foundation was the one that I just kind of gravitated towards. I don't know why, but I'm so grateful that the Jett Foundation exists, because honestly, I don't know where I would be without the women that persisted, but gently persisted, letting us know that it's going to be okay. And that such a fantastic community wrapped around this horrible disease. I don't know what our future looks like. I have no idea. And I think that was the hardest thing that I've had to process, was that my expectations for his future, it was done. And not that I gave up hope, not that I lost my faith. It just was, wow, like, you really don't realize like how much you put the thought into just normal expectations, getting married, having children, seeing that progression. And I'm not saying that that's not in his future, but you really do start to understand that that's a possibility that may not happen. But in the last 9 months, it has been bittersweet, because we're just starting to comprehend like what this really means, like what this disease really is. And for the young men that are in their positions right now, like, you guys are just phenomenal. The parents, the moms and dads, especially the dads that just sit and take it in and just shove it down and go to work every day and do what they need to do to provide their families. Like, I just commend you guys very much, because as women, I think we just externalize, and we have to talk about it, and we deal with it. And I don't know if I could survive like that, but we are on this journey, and I was kind of asked to express and just talk about a little bit about what we're going through, and it's a very touchy situation. But I do feel like it's necessary to talk about, because the world is changing. And we were diagnosed at CHOP, and we decided that just recently that we were going to take a leap of faith and come to Penn State Hershey. And we recently had our first visit with Dr. Paul on the 29th, and I think he is pretty incredible. I felt very understood, very listened to, very just the compassion that he had, which I feel like is very hard to find anymore, especially in this world, because everybody's going through something, and I feel like we're all kind of tapped out. And sometimes that empathy just starts to dissipate. But he listened, and he's our son. Like, he is our son. We are responsible for his life. We helped create him, and I have a very hard time with it, because I feel like we're just meant to dedicate his life to science, and it's very, very hard for me, being so new to this, and all of the moms and all of the families that are in this and are going through this. I can't express to you the gratitude that you have walked this life for so many years. You are incredible. But it's very, very hard for me and my husband and our family to look at Killian and just say, well, we're dedicating him to science. And I felt like Dr. Paul really understood that. Like, he actually had a moment in our visit where he was like, what would I do if this was my child? And he just sat back and, like, I didn't ask that question. He just came out of nowhere and said this. And it was like one of those moments where he felt it. And he didn't answer that question, because we got onto another topic, but it was like he really, truly was thinking. And that was probably the first time I felt understood. And I know that we haven't been going through this very long, but I don't know what we're supposed to do next. I don't know. And the reason why I say this is because so we have chosen to not vaccinate Killian. And this has come up a few times, and we are understanding of why the vaccines are important. but at the same time, we just have concerns. And so Dr. Paul had understood this. He was listening, he was understanding, and it seemed like he was going to go the extra mile for us. But at the same time, he did explain to us that it's a very, very slim chance that we will have any sort of treatment for Killian if we do not fully vaccinate him. But at the same time, he did say to us that there was just another family that went from CHOP, that went to Children's Nationwide, is that what it is? Went to Hershey, and all of them had decided that because they did not vaccinate their child, that they would not treat this 4.5-year-old. And he shared this information with me, and he said, we've tried to reach out to them, but they ended communication with us after we told them that there was no treatment option. And I don't know where we stand. I don't know what we are going to do. But it hit me so hard, and I called Alexa after this appointment, and I'm not disheartened, and I don't feel like the wind was knocked out of my sails, but I feel like there is a moment where there are families like our family where we have chosen a certain option, but we feel now we were put into this bubble of Duchenne, and we just don't know where to go from here. There's nobody wants to kind of deal with us because we've made such choice. And I was asked to share this, and I do want to share this, but it is private, it is personal, but so you're in our personal little bubble now. And I know it's touchy, but it is a choice that we have made, and we have to walk this path. But there are others like this. And I just hope that we are able to have these open conversations with pharma, and hopefully there can be advocacy for these families, because their lives and they matter, and we all just want a fair chance at life on this earth while we are here. We want the quality. But that's where our story has ended right now, because we are in the beginning period at Hershey, and we have our appointment coming up in February to start clinic, which we never got that far at CHOP. And so I'm really excited to see what's in store for Killian and how we can navigate this world, especially now that we have an extra layer added onto this Duchenne journey. But if anyone has any advice or any suggestions for my husband and I, or for the families like us, please reach out to us or the Jett Foundation, and just let them know what options we may have, or if maybe there could be a trial, or maybe there can be a group for families like us, because there are boys out there. And the way the world may be changing, maybe there will be more. I don't know. But maybe there's hope. And that would be the best thing that we could come out of all of this, just some hope. But that's all I have. Thank you for listening. Thank you so much for this great opportunity, and just thank you.